Look at these two readings. They look almost identical, but they differ in one thing, and that is the QT interval, where one is prolonged and the other is shortened, and that difference can be explained by calcium. To see why, we have to focus on the ST segment. It represents the plateau phase of the cardiac action potential, where L-type calcium channels are active. So calcium determines how long the plateau lasts, and that changes the ST segment, which changes the QT interval. And that's why calcium can shift the QT interval without changing the P wave, the QRS, or the T wave. The L-type calcium channel is voltage gated, but it opens late, around minus 40 millivolts. It opens and inactivates slowly, so it stays open for hundreds of milliseconds. And that sustained inward current is the plateau. And here is the part that matters. Throughout the plateau, the inward calcium and the outward potassium currents almost cancel. The beat only ends when that balance tips outward. So the question is, what tips it? Think of it that way. Potassium grows, but slowly and on the same schedule every beat, so it's like a fixed drain. Meanwhile, calcium is the tap water holding the level up. It only falls when the tap closes. So potassium finishes the beat, but calcium decides when potassium gets the finish. And because the two nearly cancel, a small change in calcium can move that moment a long way. And once the voltage does start to fall, the potassium current grows fast, which causes phase 3. So when does the calcium current fade? The calcium channel is made so that it shuts itself off when the calcium comes through it. So that means that more calcium coming through causes a faster shutdown, and less calcium causes slower shutdown. That is what is known as a calcium-dependent inactivation, which I went through in the video linked below. One more thing to keep in mind before we go to pathology is that the same channel is also responsible for the upstroke in the SA and AV nodes. Now let's look at hypocalcemia. That means that the serum calcium is low, which in turn means that less calcium comes through each open channel. That means that there is less inward current to balance potassium, so it should win sooner. So the obvious prediction is a smaller plateau that ends early. And half of that is right. The plateau does sit lower because less current is holding the voltage up, but it does not end early. Because height is set by how much current flows in the moment, and length is set by how long it keeps flowing. So less calcium arriving means the channel is slower to shut itself off. The current is smaller, but it lasts longer. On the ECG, that would mean that the ST segment stretches, so the whole QT interval gets long. The only other thing that suffers is the calcium pump. Because less calcium comes in, less gets released from the store, and in turn, less strong contractions happen. And that would in severe cases cause hypotension. Now on to hypercalcemia, which means that serum calcium is high, which in turn means more calcium through the channels. And we know that more calcium arriving means the channel shuts itself off faster. So potassium wins the balance sooner, which means that the plateau is cut short. And on the ECG, it shows as a shorter ST segment. And if we push it far enough, the ST segment can almost disappear. So then the T wave looks like it is sitting straight on the QRS. In severe cases, you can also get an Osborn wave, also known as the J point, which we'll explain later. Calcium also affects the electrical activity of pacemaker and conduction cells. Outside the membrane, calcium screens the fixed negative charges near the L-type calcium channels. This shifts their activation threshold to more positive voltages, making them harder to activate. In severe cases, this can slow down the nodal activity and conduction, leading to bradycardia and AV blocks. Calcium can also overload the sarcoplasmic reticulum, and an overloaded store can spontaneously release calcium. The sodium-calcium exchanger then brings in more sodium as it removes the excess calcium, creating a net inward current. This depolarizes the cell and can trigger an extra beat. This is called a delayed after depolarization, and it's the same calcium overload mechanism that is responsible for the arrhythmias seen in digoxin toxicity. Contractility also rises here, because there is more calcium available. So the picture here is a short QT, a slow rate, and a ventricle that is prone to triggered beats. The Osborn wave isn't a separate fact to memorize. It comes from a difference in how the outer and inner layers of the ventricle repolarize. Cells on the outside have a strong transient outward potassium current. Right after depolarization, this current briefly pulls their voltage downward, which creates a small notch in the action potential. Meanwhile, cells deeper in the ventricular wall have much less of this current, so their action potentials don't develop the same notch. That means that for a brief moment, the outer and inner layers of the ventricle have different voltages. When the difference is large enough, it appears as a small deflection around the J point, which is known as the Osborn wave. Normally, this difference is small enough that the wave is barely visible. But in severe hypercalcemia, one of the proposed mechanisms is that the increased calcium shortens the plateau of the action potential, allowing the outward potassium current to dominate earlier. That can make the notch more pronounced in the outer cells, which increases the voltage difference across the ventricular wall and causing the Osborn wave. To summarize, one property explains everything. How much calcium arrives decides how fast the channel shuts itself off. That sets how long the ST segment lasts, how big the threshold is, and it even explains extra beats.